Hello. Hi everyone. So welcome to this session. One shot ENT for FMGE batch. So I intend to complete this session in around 2 hours. So sit tight, make your notes, and most of the things that we're going to discuss are going to be important from your exam point of view. Right. So uh, now before I start, I want to show you these topics, the important topics. You can note this down. These are the topics from ear. You see, anatomy is very important. Anatomy of ear. Otitis media. All the type of otitis media. The images are important. Then simple disease like autosclerosis, Meniere's disease, tumors like acoustic neuroma, glomus tumor are the important topics from ear. And cochlear implant, they have asked once or twice a question, so that becomes an important topic. These are throat topics. Okay, so throat, again, these are the important topics. Anatomy of larynx especially is important, but anatomy of larynx is mainly discussed in general anatomy. In throat, tumors are important like nasopharyngeal carcinoma, laryngeal carcinoma, benign tumors like papillomas, angiofibromas. These are the kind of important topics from the throat, and these are the topics from nose and sinuses. Okay. Now, before I start the actual topic, I just want to show you a very important course that we have launched for FMG aspirant for June 24. You can see here that for FMG aspirant June 24, we have launched this program where in 5 months, it's a revision program where in 5 months, we are going to discuss all the 19 topics in 5 months. There'll be practice with schedule of text, and you'll also get very important FMG basic plan till 31st July. This is face program at 2 centers, one in Delhi, Gautam Nagar, the other one in Jaipur. In Gautam Nagar, Delhi, and Jaipur, there are 2 centers. So anybody who's planning to write the exam in June 24, this is the best opportunity. Although the MRP, the fee for this program is nearly 50,000, but for the first 50 students, there is a huge discount. We're offering it at 20,000. So grab this opportunity, guys. And this is the schedule for the one shot that is going on. Today, we have done orthopedics already on the first. Today is third, ENT, and onwards, as you can see here. We must be having the schedule already, I'm sure. So with this detour, we are ready for the real thing. We'll talk about ear first, then throat, and eventually nose and sinuses. Once again, in around 2 hours, I intend to complete everything. Now, ear anatomy becomes important. From the anatomy, there is external ear, middle ear, inner ear, isn't it? In the middle ear, we all know middle ear is a cavity with 6 boundaries and 3 compartments. But what are the main things that you have to know? The structures in the middle ear. There are 2 very important structures in the middle ear that are important. One is the eustachian tube and the other is stapedius muscle. In the last moment, if you revise middle ear, these are the 2 things you must look at: eustachian tube and stapedius muscle. Right. Now, I'm sure for those who know the anatomy, will know that eustachian tube is on the anterior wall of the middle ear. It lies on the anterior wall of the middle ear, and it's 36 millimeters long. And the main function, this is what they ask you actually, what is the function of the eustachian tube? Because eustachian tube has very important functions, and that makes the eustachian tube so important. There are 2 important functions of eustachian tube. One is to balance the pressure of the middle ear, so we just use the word balance. and the second function is the drainage. We drain the secretions of the middle ear. And if the station tube stops functioning for whatever reason, then both these functions are disturbed, and if the balance gets disturbed, this leads to what? This leads to the negative pressure in the middle ear. And if there is a drainage problem, because the tube gets blocked, the fluid from the middle ear cannot drain out, and that causes collection of fluid in the middle ear. Now the drainage problem leads to two things. It causes retraction of tympanic membrane and also leads to barotrauma. These are the two things it causes. And if the collection is happening in the middle ear because the station tube is blocked, the fluid which is accumulating in the middle ear gets infected, and that leads to otitis media. Now otitis media is a very important topic. We are going to discuss a lot about that. But remember that the root cause of all otitis media is the station tube problem, as you can see here, right? And stapedius muscle, the other important thing, again stapedius muscle is supplied by facial nerve. The nerve that supplies the stapedius muscle is facial nerve, the seventh cranial nerve. Now for those who know any ENT will know that facial nerve is the most important nerve from the ENT point of view. Once again, what is the function it does? What does stapedial muscle do? It dampens loud sound. What is the meaning of the word dampen? It decreases the loud sound. When the sound is too loud, it can be dangerous to the cochlea, and so it needs to be reduced, and this is called dampening. This is done by the stapedius muscle. How does it do this? By producing a reflex called stapedial reflex. See, stapedius muscle produces a reflex called stapedial reflex, which is easy, but what you have to be careful about is that this reflex has one more name, and that could be, if you're not very sure, could be confusing. It's called acoustic reflex. Okay, just remember this. Stapedial reflex, acoustic reflexes are same thing. And the last thing about this reflex that you have to know, I'm sure for any reflex anywhere in the body, there has to be an afferent nerve and an efferent nerve. And this is the most popular question from stapedial reflex. They ask you in the exam, which is the afferent nerve and which is the efferent nerve. The afferent is the seventh nerve. Again, afferent is the eighth nerve, and efferent nerve is the seventh nerve. Seventh nerve, the nerve that supplies the stapedius muscle, becomes the efferent nerve. Okay, so these are the main things in the middle ear that you have to know about. And then 2 points about labyrinth, which is inner ear. Well, everybody knows that labyrinth has two coverings. The outer is called bony labyrinth. The outer labyrinth is made up of bone, so it's called bony labyrinth. And inside this bony labyrinth is another labyrinth made up of membrane called membranous labyrinth. So two labyrinths, bony labyrinth and membranous labyrinth. Now this is how the two parts of the labyrinth looks like. The outside, this is your bony labyrinth. And if you go inside this labyrinth, you see this membrane, and this is your membranous labyrinth. What is the fluid inside the membranous labyrinth? Inside the membranous labyrinth is the endolymph, and between these two labyrinths, bony and membranous, there is a fluid called perilymph. Okay, so these are the two fluids in the inner ear, perilymph and endolymph. And the only important thing about these two fluids is what is the difference between these two fluids? What makes them different? The ionic composition. Perilymph, the main ion is the sodium ion, and endolymph, the main ion is the potassium ion. That's all about this. Sodium ion versus potassium ion. And you should be able to identify this image, and this yellow thing is the cochlea, which is the most important thing that you should be able to identify if they show you the image. And cochlea is coiled 2.5 times, isn't it? This sometimes controversial. They ask you how many coils cochlea has. Cochlea has 2.5 coils is the best answer. Okay. And tuning fork. Then we go on to the investigations. We talk about tuning fork. Now tuning fork, there are two important MCQs. We cannot talk about the details of tuning fork, but I'll give you two important questions that they asked you in tuning fork. Number one, suppose this is the right ear and this is the left ear. Obviously, the question will be a written question properly, but I'm going to ask you in the form of a flow chart, which makes it easier for you to understand. And the question goes like this: if Reni's on the right ear is AC more than BC, and Renis on the left ear is also AC more than BC. I'm sure AC more than BC is called positive Renis. Okay, so instead of writing AC more than BC, they might write positive Renis on both the sides. And if Swabax is reduced, and Swabax is reduced means less than the examiner. This is less than the examiner on both the sides. And the Weber's is lateralized to the left side. So we draw the arrow on the left side, suggesting that the Weber's is being lateralized to the left side. So they are showing you the finding, giving you the finding of Renis, Swabax and Weber's, and then they ask you that what is the problem in this patient, or what kind of hearing loss this patient has, what is in the right ear, what is in the left ear. Now one trick that I keep telling in the regular class, if the finding of Swabax is given, then it becomes an easy tuning fork test. So if this is Swabax test and this is a Swabax finding. So since Swabax is given, this is a simple tuning fork test, because when the Swabax is given, you just look at the Swabax and write the same thing. When does the Swabax decrease? Swabax decreases when there is SNHL. So if right ear has reduced Swabax, it clearly tells you right here as SNHL. Left also has reduced Swabax. So left also has SNHL. That means it's bilateral sensory neural hearing loss. Just by looking at the Swabax, I know this much. Now the next thing comes Weber's. Now look at the Weber's is lateralized to the left side, it's going to the left side. Now in SNHL, in bilateral SNHL, this is bilateral SNHL, Weber's always lateralized to the better side. So this will be better side, means this becomes the worst side. What is the meaning of that? Whenever you have hearing loss in both the ears, bilateral hearing loss, like in this case bilateral SNHL, they are never equal hearing loss. One ear is always better than the other side. One is better ear, one is worse ear. In SNHL, Weber's goes to the left side, to the better side, and since in this case Weber's is going to the left side, left becomes the better ear. So right has more SNHL. Right has more SNHL than the left side. This is what is, so this is your complete answer. Okay, this is your complete answer. Okay, let us look at another example. If this is the right ear and this is the left ear, right is AC more than BC, left is BC more than AC. Weber's is reduced on the right side, reduces increase on the left side, and Weber's is going to the left side. So once again Weber's is given along with Swabax is given along with Weber's and Renis, and once again it becomes a simple question because Swabax is given. Now when does Swabax reduce? You tell me. SNHL. So Swabax right is SNH. And when does Swabax increase, like in left ear? When there is CHL. And so the answer is right SNHL and left CHL. Simple question. And this is proven by Renis and Weber's also. In SNHL, Renis is supposed to be AC more than BC. It is proving. In CHL, Renis is supposed to be BC more than AC. And again, there is a proof there. It's shown there. In SNHL, Weber's tends to go to the opposite side. See, right is SNHL, Weber's is going to the left side. So it happens like that. And in CHL, Weber's goes to the same side. So because left is CHL, Weber's must go to the left side. It is indeed going to the left side. So everything is confirming this diagnosis. Even if this is not given here, still we get the correct answer. Okay. And if it is given like this, it's more in sync with our answer. So these are the types of questions they can ask you in tuning fork, and these are the two most popular tuning fork questions they've been asking in the exam. So it needs a lot of background to this. I'm sure you have read or done the regular classes, you have watched videos, and how we come to this conclusion, we cannot discuss the details in this one short session, obviously. Okay, now tympanometry there are two things you have to know. A, they ask you that what is the most common frequency we use in tympanometry. The most common frequency that is used in tympanometry is 220 Hertz. This is MCQ. And the only other important thing about tympanometry is the type of tympanogram. Although there are 5 types, there is A type, there is AS, there is AD, B and C. So there are 5 types: A, AS, AD, B and C. I will tell you only 2 out of 5 because these are the only 2 they will ever ask you. They will not ask you the rest of it. When you get AS type is a very popular question, and when you get a B type is a very popular. That's all you have to remember. So you can ignore the rest of them. AS, S should remind you of sclerosis. So any disease with sclerosis in the ear will give you AS, and there is a very popular disease called autosclerosis. So remember this, autosclerosis will give you AS type of tympanogram, and the other one they ask you is B type. Now before that, B is also called flat tympanogram. This is another question. What is flat? B type is called flat. And when do you get this? In a case of serous otitis media. Okay, B type is seen in a patient of serous otitis media. So remember these 2 questions. So this was about tympanometry. And then there are 2 other investigations that you should know the names of. One is called BERA, short form is BERA. The other is OAE. Now BERA and OAE, I have written the name together because the use of both these investigations is the same. But before I tell you the use of these 2 investigations, I must tell you the full form of BERA, which is brainstem, evoked response audiometry, is the full form. And OA, you don't have to know the full form, you have to know who produces. O is an emission, E stands for emission, and they ask you a very popular question, who produces this emission? And this emission is produced by the outer hair cells of cochlea. So this is a very popular MCQ. So I have written here MQ because it's a very, very popular MCQ. Who produces the OAE? Okay, remember that. And then you have to know, I told you I've written both these names together. Why? Because the use is the same. What is the use of BERA and OE? They are both used to screen or confirm hearing loss in newborns, in a newborn child. So if you want to confirm a hearing loss in a newborn child, whether the child has a hearing loss or not, you can do any of the 2. But tell me something. If suppose there is a question which says which of the following is an investigation of choice for hearing loss in a newborn child, which of the following is a investigation of choice for a newborn child in a newborn child, and both are given in the choice. One choice is BERA, one choice is OE, and you know both are correct answer, but you are allowed to pick only one correct answer. So which one do you pick up? It's like asking which is a better answer, OE or BERA. Then OAE is a better answer because that is the first investigation we do in a newborn child, OAE. Okay, but there is a second use of these 2 investigations. What is the second use of these 2 investigations? They are both used to differentiate between cochlear disease and retrocochlear disease. Now, whether it is disease of the cochlea or retrocochlear disease is a disease of the 8th nerve. If the 8th nerve has a disease, it's called retrocochlear disease. Now, disease of the cochlea and disease of the 8th nerve, they both cause SNHL. We just discussed in audiometry, there is tuning for SNHL, sensory neural hearing loss. So, sensory neural hearing loss can be due to disease of the cochlea and disease of the 8th nerve, which is called retrocochlea. So, in SNHL, we have to know, is it cochlea causing SNHL or the 8th nerve, which is retrocochlea causing SNHL? So how do you find out that? And you can do any of the 2 investigations. Once again, you can do BERA or OAE. So these are the two U's of BERA as well as OAE that you need to remember. Okay. Now, so this much about the hearing test, and then we have a caloric test. Caloric test can be called a vestibular function test. And in this test, when you do the syringing in the ear with cold water and warm water, the patient begins to have nystagmus. Nystagmus is the end result of this test. And the question that they ask you is which ear will have nystagmus during the caloric test. And that we all know can be answered with these mnemonics called COWS, where C stands for cold water, 30 degree. If you syringe with 30 degree, it's called cold water. And the nystagmus happens to the opposite side. If you syringe in right ear, the nystagmus will be on the left side. And if you syringe in the left ear, the nystagmus will be on the right side. So opposite to the ear that you are syringing, you will get the nystagmus. And W stands for warm water, which is at 44 degree. And S stands for same side. Okay. So cold water causes nystagmus to the opposite side, and warm water syringing causes nystagmus to the same side. It's a very popular question. I'm sure most of you know this already because we discuss in every platform and forum about this COWS. Okay, so I'm talking about the anatomy, few investigations which are very, very important, and then we talk about the inflammatory disease of the ear, otitis externa, otitis media. In otitis externa, the only important otitis externa is malignant otitis externa. And you know, when they ask you a question on this, usually they give you a history like a 60-year diabetic with pain and discharge. So if they use the word ear problem with diabetic who is around 60, 70 and all that, this is the thing that should come to your mind, and it's caused by pseudomonas. Remember this. So once they give you a history like a 60-year-old diabetic with pain and discharge from the ear and all that, they ask you either the diagnosis or the drug of choice. There are two things they'll ask you. Diagnosis obviously is malignant otitis externa straight away, and drug of choice is another important thing. Drug of choice is third generation cephalosporins. Okay, so these are the two questions they ask you, either drug of choice or the diagnosis. They'll give you a history like this. Now, very important finding in the history they give you when they ask you a question on malignant otitis externa, on examination they'll say there is granulation in the canal, because this is a diagnostic finding in malignant otitis externa. There is no other external ear disease which causes granulation in the canal except malignant otitis externa, and that's why it becomes very important. And talking about the treatment, drug of choice, although they ask you the drug of choice and the answer becomes third generation cephalosporins, but along with this, anti-diabetics are very important, because if you cannot control diabetes, this treatment usually does not work, right? So this is the only important disease from the external ear which is important. But in the middle ear infections, there's so many otitis. We'll talk about ASOM, we'll talk about serous otitis media, we'll talk about CSOM, and we'll talk about colostoma. So many types of inflammatory disease in the middle ear, they're very, very important. Now ASOM is caused by three pathogens. It's caused by strep pneumoniae or pneumococcus as it's called sometimes, plus Haemophilus influenza plus Moraxella. These are the three pathogens which are involved in ASOM. Again, pain, discharge and all that. And on examination, out of many findings, one I'll tell you, there is something called cartwheel appearance. is this called cartwheel appearance. Then this fluid level can be seen. And there are two very important signs called lighthouse sign and there is another sign called reservoir sign. So remember these very important points about ASOM. This is the only thing. And in the treatment of ASOM, there are two questions. First line of treatment and treatment of choice. Now you have to be very, very careful about the language of the question here. Is it the first line of the treatment or the treatment of choice? With the answers can vary. In the first line, we give very important nasal decongestants. These are nasal drops. And obviously because a bacterial disease, there are 3 bacteria in the beginning of routine, so you have to give antibiotics. Okay, so this is the treatment in the initial part. But if they change the question and they ask you the treatment of choice, same thing plus myringotomy. Myringotomy is a type of surgery. I'll show the image of myringotomy, how it's done later on. But remember this much. So these are the points about ASOM that what one might remember. Name of the pathogens, the signs, and the initial treatment, treatment of choice, both can be correct question. The other one is serous otitis media. This is serous otitis media, also called otitis media with effusion. Now very interestingly, it's the inflammation of the ear without any pathogen. There is no pathogen in the middle ear. So if you aspirate the fluid from the ear and send for culture, it is going to grow nothing. It's going to be a sterile fluid, and this is the most common cause of hearing loss in children. This is a potential question, that which of the following is the most common cause of hearing loss in children? Very commonly asked question. Then the answer is serous otitis media with effusion. Now there are two very, very important MCQ. One is the investigation of choice and treatment of choice. Now investigation of choice, I'll tell you the name of the investigation and you try to give me the answer. What is the finding? The investigation of choice is an investigation called tympanometry. And if I ask you, what type of tympanogram do you expect in this patient? What do you say? What is the answer? The type of tympanogram, B type. Remember, B type is also called flat type. I told you there are two tympanograms important, AS and B. So B comes back again. And treatment of choice is very, very important. What is the treatment of choice in this patient? It's myringotomy, plus grommet insertion. Now this much most people know. I'm assuming that most people know this much, but what people forget, that you have to look for a choice which also says plus adenoidectomy, because the cause of glue ear, serous otitis media, is adenoid hypertrophy, and therefore adenoidectomy should be a part of the treatment. So this whole thing is a treatment of choice for serous otitis media or otitis media with effusion. So remember these very simple points. And the last otitis media is chronic suppurative otitis media, which can be safe CSOM and unsafe CSOM. Safe and unsafe. In both, they are going to be purulent discharge, pus discharge, and tympanic membrane perforation. Without these two, you cannot make a diagnosis of CSOM. In CSOM, diagnosis is only made when you have both these things. There has to be a history of purulent discharge, pus from the ear, and tympanic membrane more than 3 months. See, chronic. So you have to justify why do you call it chronic. It has to be a long duration, more than 3 months. So in both safe and unsafe, it is the same thing. The main finding is the same, purulent discharge with perforation for more than 3 months. So how do you know, is it safe or unsafe? In safe CSOM, no smell in the discharge, and central perforation. Perforation is seen in the center of the tympanic membrane. Whereas in unsafe CSOM, there is a foul smell in the discharge. It's not smelly, it's very smelly, and it's marginal perforation. Perforation is not in the center, but in the margin of the tympanic membrane. Okay, and treatment for safe CSOM is different for unsafe CSOM. It is different. Any idea what is the treatment for safe CSOM? Myringoplasty. It's a surgery called myringoplasty. Of course, you can give medicines and all that, but we are talking about the main thing. In unsafe CSOM, again there is a surgery called MRM, and I'm sure you know MRM stands for modified radical mastoidectomy. MRM is modified radical mastoidectomy. So CSOM can be two types. Both will have purulent discharge with tympanic membrane perforation for more than 3 months. If it is foul smelling discharge with marginal perforation, it is unsafe CSOM, and then you do MRM treatment. But if there is no smell and there is a central perforation, then it is safe CSOM and you can do myringoplasty surgery. And in CSOM, sometimes we see colostoma also. Now colostoma is a feature of unsafe CSOM. Okay, what is a colostoma? It's a sac of keratinized squamous epithelium. This is the definition of colostoma. It's a sac of keratinized squamous epithelium in the middle ear, and the most common site of colostoma is the Prusac space. Now, if you ask me how does colostoma present, I just told you the answer. How does colostoma present? I'm telling you, I just told you the answer. Did I tell you the answer? Can you write in the comment if you know the answer, that how will a colostoma present? I'm telling you that I told you the answer. Did I? I didn't tell you the direct answer. What I told you is that colostoma is a feature of unsafe CSOM. Did I tell you that? It is a feature of unsafe. So now it will present as unsafe CSOM, which means foul smell, purulent discharge plus marginal perforation. See, indirectly I told you the same thing. So sometimes you have to be very careful, very sharp when you read. These kind of things are given in the books also, and they frame questions accordingly. So what is the treatment for colostoma? Because colostoma is the feature of unsafe CSOM, the treatment is the same as unsafe CSOM, which is MRM. MRM should be the treatment of choice because it is unsafe CSOM. No? So that's how we relate. Okay. Now, Bell's palsy is a facial nerve palsy. It's a facial nerve palsy. Bell's palsy is the most common cause of facial palsy. Because facial palsy can have so many causes. There are almost 40 causes of facial palsy, so many. Out of all those possible causes of facial palsy, this is the most common cause. And it's idiopathic. Idiopathic means where you do not know the cause. Bell's palsy is the other name for idiopathic facial palsy, or the cause is not known. Now, if you do not know the cause, if it is idiopathic, how do you treat is a very potential question. So what do you do in Bell's palsy? The main thing are steroids, but steroids are given for 2 to 3 weeks, long duration. Steroids have a lot of side effects, we all know this, and so we are always reluctant to give steroid for a longer duration of time, but here you have to give for minimum of 2 weeks. And some book says that you should add acyclovir, but I'll tell you with all confidence that acyclovir is not used in practice. In latest books they say acyclovir should not be given, but because acyclovir is written in your MCQ books, I am writing for that purpose. However, the more important question is there is no response. You have given steroid to the patient of Bell's palsy for 2-3 weeks, but the patient is not showing any response. Then what do you do? That's the question. And the answer is decompression of facial nerve. This is a short answer. Decompression of the nerve has to be done if the steroid fails to improve a patient of Bell's palsy. Okay, so this was about Bell's palsy, facial palsy. And so this will cover all the inflammatory diseases that we have to know, the brief of it, few points. And then we talk about surgeries. We have mentioned two surgeries, sometimes laryngoplasty and MRM and all that. We'll discuss two important surgery. One is tympanoplasty. You know what is the meaning of tympanoplasty? Tympanoplasty is a surgery where you do laryngoplasty plus you do ossiculoplasty. So when you do both these things, tympanoplasty is when you do laryngoplasty plus ossiculoplasty, the common name for these two surgeries is tympanoplasty. And this is the most important disease surgery of the year from the exam point of view. If they want to ask you a question on surgery in the year, it is 9 out of 10 times going to be tympanoplasty. Why is it so important? Because it has so many types, as you can see on your screen. There are 5 types, and any surgery which has 5 types, that means there are so many permutation and combinations possible. So many questions can be framed, but I'm only giving you the most important thing they can ask you, that some of these types have other names which are given with blue color, written there in blue color. Type 1 is called laryngoplasty, it's written there, but type 2 has no name. Now very interesting, type 3 has 2 names. Type 3 is called columella as well as stepidomeryngopexy, and that's why it's such an important MCQ, because there are 2 names for the same type. Columella in fact is a very important MCQ which has been asked so many times. Type 4 again has no names, but type 5 has a name called fenestration surgery. So if you have noticed, the odd ones have names. 1, 3 and 5 are odd numbers. They have names like laryngoplasty, columella, stepidomeryngopexy, fenestration surgery. The even ones like 2 and 4, these are even numbers, they don't have names. So remember that much about tympanoplasty. And 2 points about MRM, mastectomy. Now mastectomy can be a simple mastectomy. MRM, this name I had mentioned during unsafe CSUM and colostoma, and radical mastectomy. Now simple mastectomy has 2 more names. It's called Swart surgery and it's called simple mastectomy, cortical mastectomy. Now MRM has 2 subtypes. One is called canal wall up surgery and one is called canal wall down surgery. And then we have radical mastectomy. Okay, now these are the types of mastectomies that you have to know. The only important thing are the main indications. These mastectomy surgery, they have many indications. They can be done for many diseases of the ear, but you have to know the most important indication for simple mastectomy is acute mastoiditis. Remember this. And all other mastoid surgeries, they are done for unsafe CSUM. We just discussed that MRM is done for unsafe CSUM. Radical is also done for unsafe CSUM. So these are the surgeries of the ear that you have to know. Okay. Now, so these are all related to infections. All the diseases that we have discussed in the surgery, they are all related to the inflammation of the ear. Now we shall discuss few diseases which are non-inflammatory diseases, but they are very important. 4 diseases which are very important. Glomus tumor. 4 points, maybe 5 points. Glomus tumor is a type of paraganglioma. Remember this very important point. It belongs to a group of tumors called paragangliomas. And in presentation, there is a very important feature called pulsatile tinnitus. We all know tinnitus, where the patient hears sound in the ear. In this patient, that sound is pulsatile. So remember this very important name. And there are 4 signs. That's why it is important. There are 4 signs to remember, and they are called rising sun sign, brown sign, Phelps sign, and equinocyte. And why? So there are 5 names to remember: pulsatile tinnitus and 4 signs. And the fact that is a type of paragangliomas. The management is not very important. They don't ask you they've never asked about management of glomus tumor, but still I'll tell you the investigation of choice is contrast enhanced CT scan, CECT as we call it, and the treatment of choice, benign tumor, say benign tumor of the ear. In benign tumor, surgery is always the best option. So we first do embolization, followed by surgical excision with either laser or cautery, bipolar cautery. You can either use laser or bipolar cautery to excise, but before that you do embolization. Now ignore the management part. Remember these names, the signs, and the rising pulsatile tinnitus, things like that. So these are the points about glomus tumor of the middle ear. And then this is the second most important disease of the ear from the exam point of view. Most important diseases are otitis media. There's so many types we have discussed, so there's so many potential questions. But otosclerosis is a non-infective disease of the ear, which is most commonly asked. Now there are a lot of points here. Site. Anybody who knows the site of otosclerosis? The site is called fistula antefenestrum. It's a very important question. You know why this is such an important question? The most common site of otosclerosis is fistula antefenestrum, because a lot of people think that otosclerosis arises in the oval window, many things it is in the footplate of the stapes, many things in the stapes, ossicles. All these are wrong answers, right? Fistula antefenestrum is the correct answer. Now when they give you a history based question, how does the patient present, how the patient of otosclerosis present, then usually they write a history which will go like this: 35 years old pregnant lady. Now please note, the age of the patient will be around 30, between 25 and 30, always 25 and 35. So 35, and the patient will be pregnant. If a 35-year-old lady around that age, pregnant with conductive hearing loss, CHL as we call it, then the only thing that come to your mind is otosclerosis. There is no other disease of the ear with this typical presentation, and otosclerosis almost always presents like this. Then there are signs also. In this also there are signs. There are 2 important signs in otosclerosis. One is Schwartz sign, and paracusis will be seen. Now investigations and test, there are 2 or 3 important points here you have to remember, which are asked in otosclerosis. Number 1, there's a very special tuning fork test that can be done here, and that's why they ask. There's a very special test called Gale's test. It's a tuning fork test, and in otosclerosis it's negative. So if this is how they ask you, what is negative Gale's test diagnostic of? And the answer is otosclerosis. Now pure tone audiometry, PTA stands for pure tone audiometry. There's a very special type of audiogram called Cahardt's notch. Another very, very important point, that Cahardt's notch is seen in which disease? Cahardt's notch is seen in otosclerosis. Very important point. And tympanometry. Now you will tell me what kind of tympanogram, because I have already talked about tympanometry. Remember AS tympanogram? AS type of tympanogram is diagnostic of this condition. This is the investigation of choice. And once you confirm tympanometry AS type otosclerosis, treatment. But before I tell you the treatment of otosclerosis, there is a syndrome which may have otosclerosis as a feature of it. And what is the syndrome? Van der Hoef syndrome. And this syndrome has 3 features. What are the 3 features of Van der Hoef syndrome? You can see on your screen. There's osteogenesis imperfecta, there's blue sclera, and autosclerosis. Another very important thing, with these three are together, it's a syndrome called Van der Waals syndrome, right? And then treatment. Now there are two things, treatment of choice and drug of choice. Now if I write like this, one is treatment of choice, one is drug of choice, that means treatment of choice is not a drug. So in this case, the treatment of choice is a surgery called stapedectomy. Either stapedectomy or stapedotomy, both are acceptable. If you have to select one of the two, stapedotomy actually is a better answer. So second name that I have written is a better answer when they ask you the treatment. It's not a medicine, but there are a lot of patients of autosclerosis where you cannot do the surgery. Then you must have a drug also. So which is the drug of choice? Anybody? It's sodium fluoride. Sodium fluoride is the drug of choice. There is no other ENT disease where sodium fluoride is even given. Only autosclerosis. Sodium fluoride is not used for any other disease. And in autosclerosis, where sodium fluoride is the drug of choice, there is no other useful medicine in autosclerosis except sodium fluoride. But surgery is a better option. So this was about middle ear disease. So this completes all the middle ear diseases that we have to know. We have discussed all the infections of middle ear, otitis media. We have done a tumor of the middle ear, glomus tumor. We have done autosclerosis. So all the important middle ear diseases have been covered. Now these are some of the images of the middle ear diseases. These are all tympanic membrane. Now if you look at the first one, this is a red and bulge in the tympanic membrane. Normal, the tympanic membrane color, I'm sure you know, is defined as, what is the color of the normal tympanic membrane? The normal tympanic membrane color is defined as pearly white, moti jaisa. In all these three images, you see it is not pearly white, it is more reddish in color, more congested. And if the tympanic membrane is congested, one thing is sure, it has to be acute inflammation. So this is acute inflammation. And in the first one with inflammation, red, there is bulging. In the second, can you see these capillaries which is dilated now? This is described as cartwheel. This is cartwheel. And look at the last one, you can see there is a fluid in the, this lower thing is a fluid. Now all the three findings are diagnostic of ASOM, acute suppurative otitis media. And in tympanic membrane, the image can be very commonly asked. They all ASOM. Any of the three images they show you, you know it is acute suppurative otitis media. Now in contrast, these are the findings of serous otitis media with effusion, the second disease that we discussed in otitis media. Now the first one is described as blue to yellow tympanic membrane, although the tympanic membrane is not blue as such, but it is not pearly white. So it's called blue membrane. And the second is described as a retracted tympanic membrane. And the third one, you can see fluid levels. In third one, they have fluid levels seen, air bubbles seen, air bubbles. And these are diagnosed, all the three are findings of SOM, serous otitis media. Okay, so look at these three images which are ASOM and these three images with the SOM, they're very, very different. In this, there is no redness. That's the main thing, difference. If you just look at it, one look and you know the difference, they're all more reddish and these are less reddish. That's the first thing. And then let me show you some perforations. Now look at the first one. This is how the central perforation looks like. And this is how the marginal perforation looks like. Central perforation is a feature of ASOM, acute suppurative otitis media. CSOM, safe CSOM. Remember safe CSOM? and marginal perforation is a feature of unsafe CSO. Look at this one. This has multiple perforation. And you know when do you get multiple perforation? In tuberculosis of the middle ear. So this is another thing that in tuberculosis, it may show you multiple perforation. Can you see there are 3 perforation? One here, one here, one here. Tuberculosis. Now these are the different types of perforations which can be shown again possible. Okay. And stapedectomy is a surgery I just mentioned. What is the indication for stapedectomy surgery? You know the answer. If I ask you what is the indication for stapedectomy surgery, in most likelihood you'll say autosclerosis, because that's what we have discussed, which is a correct answer. But remember, it can be done in only the passive stage of autosclerosis. That's the important thing. If you say autosclerosis is okay, if you can remember that it can only be done in the passive stage, that means if I ask you the contraindication, then active stage is a contraindication. You cannot do stapedectomy surgery in the active stage. Then only hearing ear you cannot do. Frequent flyers who take flights very frequently, and athletes, people who jump and run too much because we put a prosthesis that will move from its place and create problem to the patient. So these are some of the contraindications. That's why, you know, drug of choice, sodium fluoride, is so important. In all this patient, even if the patient wants to get a surgery done, you cannot do the surgery because they are contraindicated. So the patient says, you are not doing surgery, do something. So what is the something? The something is sodium fluoride. In all this case, sodium fluoride. And what is the most common complication of stapedectomy surgery? The most common complication is sensory neural hearing loss. The patient can land up with sensory neural hearing loss after the surgery. That's the most common complication. Okay. So this much about stapedectomy surgery, few points, which is done for autosclerosis. Now we go to the inner ear. We have done all middle ear, everything. A lot of surgeries we have discussed in middle ear, a lot of diseases. In inner ear, there are 2 important diseases. This is the most important, Meniere's disease. Meniere's disease, there are 5-6 very, very important points. What are the 5-6 important points? It is another name. Meniere's disease is also called endolymphatic hydrops. Is the other name for Meniere's disease. And how does Meniere's present? Now this is very important. See, in Meniere's there is, if you remember, in glomus tumor, I told you there is a pulsatile tinnitus. If you remember, in Meniere's there is something called fluctuating tinnitus. Don't confuse. Fluctuating tinnitus and fluctuating sensory neural hearing loss and episodic vertigo. Episodes of vertigo. So these are the 3 main complaints in Meniere's: fluctuating tinnitus, fluctuating SNHL, episodes of vertigo. And there's another question related to this. In Meniere's, how long does the duration of vertigo last? That episode of vertigo will last for more than 24 minutes. If there is a vertigo, it will last for more than 24 minutes. But in many books, you'll say 20 minutes, 24 minutes, hardly matters. Now, investigation of choice or signs. What are the important signs in Meniere's? There are 2 important signs you have to remember. One is called Hennebert sign. Anybody who knows what is Hennebert sign? And Tullio's phenomena, same thing. Anybody who knows what is Tullio's phenomena? Hennebert sign and Tulio's phenomena are the two important features. Henneberg sign, I'll tell you, it's a false positive fistula sign. Henneberg sign is another name for false positive fistula sign, which is seen in Meniere's disease. And in Tulio's phenomena, the patient will come and complain loud sound. Whenever there is loud sound around me, there is a vertigo. The patient experiences vertigo every time there is a loud sound. The patient head starts spinning. This was asked last year in your exam. In last year in your FMGE exam, they had asked that Tulio's phenomena, which is vertigo and loud sound. Now, investigation of choice, there are two correct answers. You can do MRI. MRI will show you the hydrops. This hydrops is the increased size of the inner ear. You can see on MRI. And you can do electrocochleography. These are the two important investigations that can be done for Meniere's. Any of the two is useful. And once you confirm with these investigations, treatment. Now, Meniere's is a very complex disease. It's not easy to understand. It is not easy to diagnose, and it is not easy to treat. And because it is not easy to treat, we have a lot of options in Meniere's. Like, what are the options we have? I'll write here. There is a very important drug called beta-histine, also called beta-histidine, is a very important drug. Then there is a device called Meniere's device. But now comes the most popular surgery, that is a procedure done for Meniere's disease, which is the latest and the best option, and it has two names. It's called intratympanic gentamicin. Remember this very important name, intratympanic. So there is a drug of choice, the best drug, beta-histidine. There is a device called Meniere's device. This device is easier to remember because the name of the device matches the name of the disease. Meniere's disease, Meniere's device. And intratympanic gentamicin, the best option. The last one is the best option. Now, please, guys and girls, I know of MCQ books where they have given that the best treatment for Meniere's is labyrinthectomy. The definitive treatment for Meniere's is things like that. You know, the various terms used, definitive, best, and all that. Treatment for Meniere's is labyrinthectomy. I'll tell you what, labyrinthectomy is a surgery which is not done at all. It was never done. Maybe it was done for some research purpose and all. In patient for practical situations, labyrinthectomy is only done for tumors and things like that, carcinomas in the brain, not for inflammatory, non-inflammatory disease like this one. So labyrinthectomy is almost like a crime. If you perform labyrinthectomy surgery in somebody, it's almost like a crime. You can't do that surgery. So I don't know why these books are saying labyrinthectomy is a treatment of choice for Meniere's. No. What is the treatment of choice? Best, intratympanic gentamicin. Now this is the most important surgery of the inner ear from the exam point of view. One disease where there are only 2 or 3 points, BPPV. Images are important from here. I'm sure you know the full form, benign paroxysmal positional vertigo. Now there are 2 maneuvers they ask you in this disease. There are 2 maneuvers they ask you. One is for diagnosis of BPPV and the other is for treatment of BPPV. Can you name the maneuver for diagnosis and the maneuver for treatment? For diagnosis, we do what is called a Dix-Hallpike maneuver. And for treatment, we do Apley's maneuver. Apley's maneuver is a type of canalolith. Remember this point, canalolith repositioning maneuver. Is a type of canalolith repositioning maneuver. If you look at this word canalolith, lith stands for stone. So this is a type of stone in the ear. It's actually a calcium body. It's very tiny, almost microscopic calcium body. And so this is called, because it's slightly heavy because of calcium, it's called stone in the canal, posterior canal. So it's canalolith, and it has traveled from somewhere to the posterior canal. It has migrated from its place, rightful place, to the abnormal place. So that creates a problem. So you have to send it back to where it came from. Remigration करना, जो आ गया है उसको वापस भेजना. So that's repositioning. That's what it means. And this is how you do. The first is a Dix-Hallpike maneuver, and the second one is an Apley's maneuver, a canalolith repositioning maneuver. Both these images are extremely important images. Last year, this Apley's maneuver was asked in the NEET PG exam. They can ask you this time. So the trick to identify the difference between Dix-Hallpike and Apley's is, Dix-Hallpike, they will always show you either one or two images. I've shown you two images, either two or one image only. It is not cyclical. Whereas Apley's, the niche wala, the lower one, you can see there are multiple images in one, because the patient, this has to be repeated many times, a cyclical thing. Dix-Hallpike is done only once. Apley's is repeated many times. That's why it's always seen in the form of cycle. Okay, very important images. And this will complete all the inner ear disease, mini ears and BPPV. And we discuss a tumor of the 8th nerve. Only 5 points about this tumor, very popular tumor, 8th nerve tumor, is a type of schwannoma. So it's also called vestibular schwannoma. Vestibular schwannoma. 5 points. A, which nerve does it arise from? B, which is the most common site? C, what is the first symptom? D, which is the most common manifestation? And any sign? These are the 5 questions they ask you, but I'll give you 2 more after this. So which is the most common nerve this tumor arises from? It arises from inferior vestibular nerve. Which is the most common site? CP angle is what we call it. It's called cerebellopontine angle, also called cerebropontine angle, CP angle. Now you have to be careful. First symptom is tinnitus and sensory neural hearing loss. But the most common manifestation is a very important MCQ. This is perhaps the most important question from this particular disease, and the answer is loss of corneal reflex. Okay, remember this. Loss of corneal reflex is the most common manifestation, or you can call it the sign also, most common sign. There's another sign called Histelberger sign. So they ask you Histelberger sign may be seen in which patient? Histelberger sign may be seen in a patient of acoustic neuroma. Now these are the 5 questions that they ask you from this disease very commonly. I told you I'll give you 2 more points. Investigation of choice and treatment related. Now investigation of choice is an investigation called gadolinium MRI. In the treatment of choice, there are 2 things. Although the best treatment is surgery, but because it's a very critical surgery, very morbid surgery, there's one more option which is very commonly done in many patients who cannot undergo surgery, and that's called, very important MCQ also, gamma knife stereotactic radiotherapy. It's a type of radiotherapy. Okay, so 7 points in all about acoustic trauma, and this completes all the important diseases from the external ear, middle ear, inner ear, 8th nerve. Every part of the ear we have discussed all the important diseases, all the important points. But there is one more topic they ask questions in ear, and that is cochlear implant. 3 questions, cochlear implant. Now what kind of a device is cochlear implant? It's a speech processor. We call it a speech processor. And what is the indication? When do we use this? The main indication for cochlear implant, when there is a bilateral severe hearing loss. If somebody has severe hearing loss in both the ears, bilateral, then cochlear implant comes into play. And now comes the most important point. What do you do in this surgery, in this implant? There's something called electrodes. The other name for electrode is stimulator. Is implanted into scala tympani. Now cochlea has three compartments. There is scala vestibuli, there is scala media, there is scala tympani. So they ask you, cochlear implant electrodes are implanted in which compartment? Are they implanted in scala vestibuli or media or tympani? The answer is into tympani. And which is the route? The route is through round window. So there are two important points here. A, where is it implanted? In the scala tympani. And what is the route? Round window is the route. Okay. So both are very, very important question about cochlear implant. And this completes everything to do with the ear. Ear is 50% of ENT. So when you plan your revision of ENT, suppose you have say 10 hours to revise ENT. In 10 hours you want to complete ENT revision. Then nearly 5 hours, 4.5 to 5 hours you devote to ear, and rest 5 hours you devote to throat and nose. But we are going to complete in 2 hours. 1 hour we have done ear. In the next around 1 hour roughly, we are going to complete throat and nose and sinuses very quickly, like we have done ear also. All the important points I'm going to give you, and in the last moment you just open this particular video and just watch it and it will be done. Okay, throat. Now in throat anatomy, tonsillar arteries are very important. Now they ask me which is the main artery of the tonsil. The main artery tonsil is tonsillar branch of facial artery, but there are 4 more arteries, total of 5 arteries. It's a very, very popular anatomy question in the throat. 5 arteries. Now there are 2 ascending and 1 descending, and they all starting with PPP. They all PPP, and the last one comes from the tongue, so lingual artery or dorsal lingual artery. 5 arteries, very, very popular question. In the anatomy of the entire throat, this perhaps the most popular question from the exam point of view, very commonly asked. But few other things like they ask about arteries and muscles and the functions. These are not per se anatomy ENT questions, they are anatomy questions. This is how the larynx looks like. Now what are the things you can identify in the larynx? There is epiglottis here, this is the hyoid bone here, this is a thyroid cartilage. Identify this membrane. It's a very, very important membrane, thyrohyoid membrane. It's written here. And cricoid cartilage is important because this is the only cartilage which is a ring-shaped cartilage. This is what they ask you, which is the only ring-shaped cartilage. Cricoid cartilage is the only ring-shaped cartilage. But the most important anatomy question from the entire larynx, A, arteries of the tonsil, which I've told you, and now these are the movement of the vocal cord and the muscle which carry out this movement. So there is abduction, one movement, there is adduction, second movement, there is tension, third movement, and all these movements are caused by muscles. Now posterior cricoarytenoid is the only abductor. See, only one name under the heading of abductor. So this is the only abductor. These are the 4 adductors: lateral cricoarytenoid, interarytenoid, thyroarytenoid, and cricothyroid. And out of these 4 adductors, these 2 are tensors also. See, if you look at these 2 names, tensors, one is this name and one is this name, isn't it? Right. Now, although we have 4 adductors, the main adductors are first 3 only. So I can strike off this name from the adductors because the main adduction is done by 3 only. Cricothyroid is a weak adductor. And although we have 2 tensors, the main tension is cricothyroid. This is a weak tensor, so I can remove this name. Okay. That means although we have 4 adductors, adduction is mainly done by 3 only. This is a weak adductor, so it's not useful as an adductor. Similarly, in the tension also, although there are 2 tensors, main tensor is cricothyroid, but thyroarytenoid is a weak adductor. So these 4 muscles, adductor, abductor, they are used for voice production, and for breathing properly. This is how they help you. Voice production and breathing. That means if these muscles are damaged, either voice will be not produced, so there will be voice change, or breathing will not be proper, so there will be dyspnea. Whereas this one muscle is the tensor of the vocal cord for high pitch voice. So if this muscle is gone, the patient's voice production will be normal, breathing will be normal, the patient will not be able to produce the voice properly. The voice production will suffer. Now these muscles, they all supplied by recurrent laryngeal nerve. So you can say recurrent laryngeal nerve, in other words, helps you in voice production properly and in breathing properly. And that's why if the recurrent laryngeal nerve is damaged, the patient will have voice change and breathing problems. Whereas extensor cricothyroid muscle is supplied by external laryngeal nerve, a branch of superior laryngeal nerve, not recurrent. This is superior laryngeal nerve, it sends a branch called external laryngeal nerve. So if these nerves are damaged, either external laryngeal or superior laryngeal, then voice production and breathing will not be a problem, because voice production and breathing are controlled by recurrent nerve. This patient will have, if the patient has a damage to external laryngeal or superior laryngeal, this patient will have a normal voice and normal breathing. The only problem this patient will have is that the patient will not be able to produce high pitch voice. Okay. So with this background of the anatomy of the larynx and throat, we'll discuss few important diseases of the throat. There's a very important disease called adenoid phasis, as you can see here. This happens when there is adenoid enlargement. If a child, a lot of children, adenoid is a type of tonsil, and if the adenoid hypertrophies, then they can have some changes on the face, and there are 5 changes as you can see on the screen. The name of these 5 changes together is called adenoid phasis. So adenoid phasis is a face with these 5 changes, and it's a very, very popular question. This was asked, a question from this was asked in the last year paper, that which of the following is a feature of adenoid phasis. So you can see there is high arched palate. The palate becomes high arch as we describe it. Then there is a crowding of the upper teeth. So upper teeth becomes prominent. Now these 2 changes both happen in the mouth. So remember this, there are 2 changes that happen in the mouth. Then there is a pinched nose due to collapsed ala and small maxilla. These 2 changes happen in the nose. And this is a face problem. Facial expression is dull. Facial problem. So if you divide like that, it becomes easier sometimes to remember that out of 5 features of the adenoid phasis, 2 happen in the nose, 2 happen in the mouth, and 1 is a general feature of the face. So that makes it easier. Okay. Now, then in tonsillitis, let me write here. Most common type of tonsillitis is catarrhal tonsillitis, also called viral tonsillitis, because it is caused by adenovirus. Second most common cause is due to streptococcal tonsillitis caused by strep pyogenes. These are the 2 most common pathogens causing tonsillitis, either virus, adenovirus, which causes catarrhal tonsillitis, or streptococcal pyogenes, which can cause many types of tonsillitis. And sore throat is the main complaint in any tonsillitis, and tonsillectomy is a very common surgery that we do. Now tonsillectomy is not done always in all patients of tonsillitis, but it's a very popular surgery which is done for tonsillar hypertrophy. Tonsillectomy, when we discuss this topic of tonsillectomy in a regular class, it is discussed under 5 headings. One of them is complications, and they ask you the most common complication of tonsillectomy surgery, and this is a very, very important MCQ, and there are questions based on this, which is bleeding. Bleeding is the most common complication of tonsillectomy surgery, remember this. And they've been asking question on bleeding during tonsillectomy very, very regularly in the last few years. So I'll tell you everything about bleeding in tonsillectomy surgery that you have to know. It saves a lot of time for you. You don't have to know. See, bleeding in tonsillectomy can be primary bleeding, reactionary bleeding, and secondary bleeding. Now, what is the difference between these 3 types of bleeding? Primary bleeding is a bleeding during the surgery. When you're doing surgery and the bleeding starts, that bleeding is called primary bleeding during surgery. Secondary bleeding is a bleeding which happens between 5th to 8th day of surgery. After completing the surgery, 5 to 8 days of surgery, the bleeding starts. That's called secondary bleeding. And reactionary bleeding is a bleeding which happens within 24 hours of surgery. So it's really about the timing of the bleeding. And now there are 3 questions which are very, very commonly asked, which I'm going to tell you. They ask you, number 1, if there is a primary bleeding in tonsillectomy, what is the commonest source of bleed? Means, does it bleed from artery or vein, or if it is artery, which artery? Remember, I gave you the name of 5 arteries. It's a venous bleed, not arteries. And the name of the vein is paratonsillar plexus of veins. Okay, so this is the source of primary bleeding, paratonsillar plexus of veins. Reactionary bleeding is a bleeding which is due to infection. Secondary bleeding is due to infection, and reactionary bleeding is due to slippage of ligature. And both this bleeding, that is secondary bleeding as well as reactionary bleeding, the main thing that you do to control this bleeding, what is the main thing that you do to control the secondary bleeding and reactionary bleeding is immediate religation. This is what you remember. Under general anesthesia in operation theater. Remember this very, very important point. This was a question asked in last year NEET PG, not in your exam, in NEET PG exam. So they can ask you very commonly that the question was like this: a patient was operated for tonsillectomy. The patient was lying in the ward. The patient started bleeding in the ward. If the patient is bleeding in the ward, it is reactionary bleeding. And the question was, what is the treatment for this? What do you do now? And the answer is immediate religation under general anesthesia in OT. That's the thing that we do for reactionary bleeding. This is the same thing we do for secondary bleeding also. Now this slide is very simple but very important slide from the exam point. Remember this everything here. Okay. Then we have these 3 diseases where the images are important. You must be able to diagnose quinsy by looking at the image, ranula by looking at the image, and Ludwig's angina by looking at the image. In quinsy, the tonsil is enlarged, you can see tonsillar hypertrophy, and tonsil is touching the uvula. It's gone up to the uvula, touching it. Ranula is a swelling in the floor of the mouth, inside the mouth on one side. Remember, ranula is on one side, not in the midline, on the corner, as you can see in the image. And Ludwig's angina is swelling in the submandibular space area here. The whole thing is swollen. Ranula is also called peritonsillar abscess. Ranula is called peritonsillar abscess. And they ask you, in peritonsillar abscess, where does the pus collect? What is the peritonsillar space? And the answer is, here the pus collects between the capsule of the tonsil and superior constrictor muscle. So this space between the capsule and the superior constrictor is called peritonsillar space. When the pus collects here, it's called peritonsillar space abscess, also called quinsy. And this condition is described as a hot potato condition because the pain is too much, and it's called hot potato condition. And now comes the most important question about quinsy. What do you do now? Treatment. And the answer is we do immediate incision and drainage followed by interval tonsillectomy. This is the treatment for quinsy. Immediate incision and drainage followed by interval tonsillectomy is the most important MCQ from quinsy. Now the names are written wrongly here. Now this is ranula and this is ludus angina. There is a printing mistake. Okay, please make a correction. Now ranula is a retention cyst of sublingual gland. We all know there are sublingual glands in this area, but this is not important. The treatment is important. And what is the treatment for ranula? It's called marsupialization. In ludus angina, only the image is important. You must be able to diagnose, but if I have to describe it, it's cellulitis. You know what is the meaning of the word cellulitis? It's a simple inflammation. Cellulitis is an inflammation of the subcutaneous space basically. So it's a cellulitis of submandibular space. But the images are more important in these three conditions. Okay. Right. And then we talk about congenital disease of the larynx, laryngomalacia. Laryngomalacia, you know, is important because it is the most common congenital disease of larynx. And it presents how? It presents with a newborn child with stridor. Stridor is noisy breathing. So child when is born, the child begins to have stridor soon after birth. And on examination, you see this image which is described as omega shaped epiglottis. And treatment is reassurance. Reassurance is like conservative management. You don't have to do much. Just give the assurance to the parent of the child. The image is more important here. And the name of the disease is laryngomalacia. So if a newborn child has stridor and they ask you what could be the cause, the first thing that comes to your mind is laryngomalacia. This is epiglottis. The shape of the epiglottis is like this, which is how we write omega. Now we come to a very important topic of vocal cord palsy. Now vocal cord palsy, another topic. Most common cause are two: thyroidectomy or idiopathy. These are two most common cause of vocal cord palsy, either thyroidectomy or idiopathic. Now vocal cord palsy can be of two important types. Now these are the two important types of vocal cord palsy. It is either abductor palsy or adductor palsy, as I've divided into two columns. Now there are four things you have to know about these two palsy. As you can see on your screen, abductor palsy is due to recurrent laryngeal nerve damage. This MCQ, they ask you what causes abductor palsy. You have to say recurrent nerve damage causes abductor palsy. And what causes adductor palsy? Vagus nerve damage causes adductor palsy. Okay. Now what is the position of the vocal cord in abductor palsy? It's paramedian position. Paramedian position is the position of the vocal cord in abductor palsy, and cadaveric position is the position of the vocal cord in adductor palsy. What is the main symptom? The main symptom will depend, is it unilateral palsy or bilateral palsy? Same here, is it unilateral palsy or both sides? In a unilateral palsy of the recurrent nerve, the first one, abductor palsy, hoarseness is the main complaint. But in bilateral palsy of the recurrent nerve, dyspnea is the main complaint, difficulty in breathing. In a unilateral palsy of the vagus nerve, again hoarseness is the main complaint. And in bilateral palsy of the recurrent nerve, aspiration is the main complaint. See, what do you know? In vocal cord palsy, you know the name abductor versus adductor, which nerve causes abductor, which nerve causes adductor, position, paramedian versus cadaveric, and the main symptom either hoarseness or dyspnea, hoarseness, aspiration. And what are the surgeries we can do? For abductor palsy, I'll tell you name of 4 surgeries that can be done, and they are very, very important surgeries. Surgery number 1 is called type 2 thyroplasty. Which is also called lateralization of vocal cord. So this is one of the surgeries. There's another surgery called Kashima's operation. Kashima's surgery. And the third surgery is chordoplasty. Out of other surgeries also possible, just remember that these 3 surgeries which are still being done. There are few surgeries name given in your books, but they are outdated surgery. I'm giving the name of the surgery which are still being done for abductor palsy. Okay. And for hoarseness in adductor palsy, I'll give you, there's one surgery, it's type 1 thyroplasty. See, this is opposite of type 2. Type 1 thyroplasty. This is also called medialization. And they don't ask you the surgery for aspiration. It's not an important question. So I'm only giving the main things. Now in vocal cord palsy, it's a very big topic. If you read your books, there's so many things given, but this slide, this last part, and this one carries most of the important information that you need about vocal cord palsy. Don't waste your time reading too much. But in this, there is a very important thing called thyroplasty, type 1, type 2. Thyroplasty is another important topic because there are 4 types of thyroplasties, as you can see. Type 1 and type 2 we discussed, but there's type 3 and type 4 also. So there's a table showing you there are 4 types of thyroplasty. What is done, like in type 1, there is medialization, which I told you already. Type 2, there is lateralization, I told you already. Type 3, there is loosening by shortening. And type 4, there is lengthening, making it more tense. It's all written there. Then is given the indications. Type 1, I just told you, unilateral adductor palsy, I just told you. And bilateral abductor palsy cause you need by type 2. But remember, type 3 is done for puberphonia and type 4 is done for androphonia. And what do you achieve by doing these surgeries? Like in type 1, it improves the voice. In type 2, it improves breathing, dyspnea is taken care of. In type 3, the pitch of the vocal voice is reduced. In type 4, the pitch is increased. So they can ask you, all the 4 thyroplasty, they can ask you the indication, they can ask you the end result, that what achievement do you get with these thyroplasties. So vocal cord palsy thyroplasty is a very important topic. You can finish it very easily. Now we come to some inflammatory diseases of the larynx. Now epiglottitis is an inflammation of the epiglottis. The main pathogen is strep pyogen and strep pneumoniae. Both are correct answers if they ask you the pathogen of epiglottitis. And the child present with fever, dyspnea, and dysphagia. On examination, you can see the images. The first one is called thumb sign. This is a thumb sign. Very, very important X-ray, very commonly asked thumb sign in epiglottitis. This position of the child is called tripod position. The child is sitting in a position called tripod, and red swollen epiglottis. Red and swollen epiglottis, because obviously epiglottis will become red and swollen, and that's the very logical thing. So any of the three things can help you in making a diagnosis of epiglottitis, which is not a difficult diagnosis. And the last thing they ask you is drug of choice. Again, third generation cephalosporin. Okay, so if a child has dyspnea, dysphagia, fever, and with thumb sign or red swollen epiglottis or tripod position, and they ask what is a potential diagnosis, epiglottitis is the correct answer. Another disease is croup. Croup is also called laryngotracheobronchitis. What do you understand from the name? Larynx, trachea, bronchus, all the three are inflamed at the same time. Laryngotracheobronchitis. It's a viral disease caused by parainfluenza virus. Again, there is a fever, dyspnea, but no dysphagia, there is voice change. And X-ray is stipple sign. This X-ray that you see is called stipple sign. It's a this thumb sign here and stipple sign, both are extremely important X-rays. If you look at this airway in the stipple sign, there's an airway is shaped like this. There's narrowing as you go up, like a steeple on the top of churches. But treatment is another. The most common thing they ask you in croup is the X-ray, stipple sign. And the second thing I ask you, the treatment, where you have to do three things. You have to give steroids to every child of croup, plus nebulization with adrenaline. These two are must, plus minus antibiotics. And in both this disease, that is croup and epiglottitis, if the child is too dyspneic, too much of difficulty in breathing, because both can have dyspnea, is written there, then you may have to give oxygen therapy also, O2 through the mouth. Okay, through the mouth or nose, oxygen. So these two are acute diseases, and in the chronic disease, there is tuberculosis of the larynx. Only two things. Most common site is posterior glottis. Posterior part of the glottis is the most common site, and there are three signs. The three signs are very important. One is called turban epiglottis. Then there is mouse nibbled appearance, and there is cobblestone appearance. Very important MCQ, these three names: turban epiglottis, mouse nibble, cobblestone. And treatment obviously is anti-tubercular therapy that is done for any tuberculosis anywhere in the body. The first thing that we always do is give ATT, right? So these are the three inflammatory diseases of the larynx, throat, that is epiglottitis, croup, and tuberculosis. And now we come to the most important thing in the throat: growths. There are so many growths that can happen in the larynx, especially glottis, and tumors. So we'll discuss some of the very important growths. So in throat, we are going to discuss the most important thing from the exam point of view. And there are a lot of images also that you should be able to identify. Let's start with growths. So nodule versus polyp. The first image is nodule. The second image is that of polyp. Now both nodule and polyp are caused due to chronic misuse of voice. Okay, and hoarseness is the main complaint, and this is true for all laryngeal growth, that hoarseness has to be the main complaint. So I'm not going to waste your time saying hoarseness in all the rest of the growths. Okay, now nodule, the site, both are seen at the junction of anterior 1/3 and posterior 2/3 of vocal cord. Now look at the first image, which is nodule. If you can see, they are very small, nodules are small. They are small, white and bilateral. Polyp on the other end are bigger, unilateral and red in color. Can you make the difference? And then look at the image. And now comes very important MCQ. The treatment of choice for nodule is voice rest, and the treatment of choice for polyp is microlaryngeal surgery. Microlaryngeal surgery is also called MLS. Now look at the nodule and the polyp, the image. I'm repeating once again. You should be able to differentiate a nodule image from a polyp image when you show you the image. Okay. Then these are the other growths: Rinke's edema, laryngocele, and intubation granuloma. Rinke's edema is not very important, so if you can identify the image, it's good. Laryngocele, you can see there is a swelling in the neck, there is an X-ray showing a swelling in the larynx, there is a CT scan showing a cystic swelling in the larynx. These are seen in trumpet blowers. People who play trumpet musical instrument with the mouth, apply pressure, they tend to have this, and it's mainly a conservative management. The image is more important. Intubation granuloma is due to intubation. So if the patient has a history of intubation, then, and you can see swellings in the posterior glottis. Can you see this is a posterior part of the larynx? It is seen in the posterior glottis. Now intubation granuloma treatment I'm writing here because you have to do CO2 laser plus you have to steroid plus Botox plus mitomycin C. Right. So these are the image, all this plus these two nodule and polyp, these are images are more important than rest of the things. These are all non-neoplastic growths. And then we talk about neoplastic growth, and neoplastic growth can be benign and malignant. So let's talk about a benign growth of the nasopharynx called juvenile nasopharyngeal angiofibroma, and this is seen in juvenile male, a male child, with epistaxis. If a male child comes to you with epistaxis, then the first thing that comes to your mind is this juvenile nasopharyngeal angiofibroma. There are two important signs. One is called antral sign, which is also called Hallmel-Miller sign, and frog face. So if a juvenile male child, a male child around 10-12 years of age has epistaxis, this is the first thing that comes to your mind. Antral sign is this image that you see below. In antral sign, the posterior wall of maxilla is pushed anteriorly. If you look at the second image, the CT scan below, look at the red arrow, which is showing the posterior wall of the maxilla is pushed anteriorly by the tumor, and this finding is described as antral sign. This CT scan is diagnostic of this particular disease, and the first image is endoscopic finding of a red mass in the nose. On endoscopy, there is a red mass in posterior nose, posterior part of the nose. Okay. Again, CCT has to be done, contrast enhanced CT scan, and treatment is same as glomus tumor, where you do embolization followed by surgical excision, either with laser or bipolar cautery, which is not important. Management is not. This names a juvenile male child with epistaxis. The first thing that should come to your is juvenile angiofibroma, and antral sign frog face. These are all features of angiofibroma, a benign tumor neoplastic growth of the nasopharynx. This another benign tumor of the larynx called juvenile onset recurrent respiratory papillomatosis. So this is also juvenile. This is also juvenile. Now this is juvenile child with hoarseness. That was epistaxis. This is hoarseness. This is the difference. They are both juvenile age group. They both have a symptom of the throat. One has epistaxis, one has hoarseness. But this one is seen only in male child, always. Whereas papilloma may be seen in females also. Right? And treatment is more important. We do multiple excision because there are multiple papillomas with microdebridement. I have to write this, you know why? Because in the olden days, we used to do multiple excision with CO2 laser. CO2 laser we are using for here. See, we are using CO2 laser for papilloma, intubation granuloma. We used to use for papilloma also, but that has been replaced by microdebridement now. So CO2 laser is an old answer. Microdebridement is a better answer. Plus, we do intralesional injections. What is the meaning of intralesional injection? Inside this tumor that you see in the image, we inject inside cidofovir. What is cidofovir? It's an antiviral. And this antiviral has to be injected locally, intralesional. That word is very, very important. Now, why do we inject antiviral in a papilloma of the throat? Because it is caused by viruses. Which virus? Human papilloma virus 6 and human papilloma virus 11. In fact, in this particular disease, this is your most important question. Which virus will cause papilloma, laryngeal papilloma? HPV 6 and 11 are the most common viruses that cause laryngeal papilloma. So these are the benign tumors of larynx and nasopharynx. Both are seen in juvenile age group. And then we talk about two carcinomas: nasopharyngeal carcinoma, laryngeal carcinoma. Nasopharyngeal carcinoma is a very, very, very important topic. Extremely important topic. But there are only 5 points and you have to know all of them. A, the site. Do you know the site of nasopharyngeal carcinoma? It is seen in fossa of Rosenmuller. Very important MCQ. Most common site. Cause viral. Although the other causes, Epstein-Barr virus. Papilloma we just discussed in the nasopharynx is caused by human papilloma virus 6 and 11. This is caused by Epstein-Barr virus. Now, in presentation, there are two things. Most common presentation of nasopharyngeal carcinoma is cervical lymphadenopathy. Cervical lymph node is enlarged. Okay, and there is a triad called Trotter's triad. Now, Trotter's triad, they ask you two questions. A, in which disease can you see Trotter's triad? Nasopharyngeal carcinoma, obviously. And why is the name triad? Because there are three features and they ask you which are these three features of Trotter's triad. You must be knowing because they are very popular. One of them is soft palate palsy, facial pain, and hearing loss. So when these three are together, it's called Trotter's triad. And treatment of choice is your last question: chemoradiation. Chemotherapy plus radiotherapy. So see, only 5 points: the site, the virus, the main presentations, what about Trotter's triad, and the treatment of choice. There is one more carcinoma which is important, and that's laryngeal carcinoma. Now, laryngeal carcinoma, although the most common site is glottis, but the question they ask you always is about the treatment. And the treatment depends on stage. Is it stage 1, stage 2, stage 3, 4A, 4B, 4C? Now, why is this important for you? You know why? Because the MCQ books are still giving you the old answers. I'll give you the new answer. In stage 1, stage 2, if you read radiotherapy as the treatment of choice, is an old answer. It's not the best answer. It is the second best answer. What is the best answer? The best answer for stage 1, stage 2 is transoral laser microsurgery. So if this name is given, transoral laser microsurgery, then that is the best answer. If it is not given, then of course you have to go for radiotherapy. Same problem with stage 3, 4A and 4B and 4C. Again, there are two things. The best treatment is concurrent chemoradiation. But please note, the word concurrent has to be there. Only chemoradiation this time is not accepted. The word concurrent has to be there. If only chemoradiation is given, then that's not a correct answer. Then surgery followed by radiotherapy becomes the best answer. Surgery and radiotherapy. Laryngectomy, obviously. Surgery is laryngectomy. Okay. In type 4C, along with chemoradiation, concurrent chemoradiation, we also do something called salvage surgery. Salvage surgery is a surgery where the size of the tumor is reduced, because 4C is the biggest tumor, last stage. Tumor is too big. So with salvage surgery, when you reduce the size of the tumor, then this chemoradiation is more effective in smaller tumors. That's the whole idea. But this particular slide is very, very important. A, because questions are very frequently asked. They'll give you the stage of the tumor, larynx, and they ask you the treatment. Especially because this is the best options. Most of the MCQs are still giving you the old answers. Even people are teaching the old answers. That's why you have to be very, very careful. But this completes all the important laryngeal diseases you have to know. But there's one more topic of throat, tracheostomy. Most common indication for tracheostomy. What do you do tracheostomy for? When the larynx obstruction due to laryngeal carcinoma. This is the most common indication. Laryngeal obstruction due to laryngeal carcinoma. Which is the preferred site? Ring 2, ring 3 are the preferred site. If you do in ring 1, it's called high tracheostomy. And now comes another very important MCQ. The only indication for tracheostomy in ring 1, which is high tracheostomy, is laryngeal carcinoma. Remember, this is very important MCQ. The only indication for high tracheostomy is laryngeal carcinoma. And complications. There's a very long list of complications. I'll give you two: bleeding and dislodgement of the tube. The tube comes out. That dislodgement of the tube means the tube will come out, and that's a very dangerous situation. Okay. Now, these are the tracheostomy tubes. The first one is non-metallic. The second one is metallic tube. And these are some of the prostheses that we use for speech rehabilitation. After tracheostomy and laryngectomy, the patient cannot speak because of tracheostomy or laryngectomy. So we do speech rehabilitation. Speech rehabilitation. So these are the prostheses. This one is called Muir-Passe valve. These two are same, called Blomsinger. And these two are less important, but the names are given: Pangen, Groningen, and Pangen, the names are given. So these are the valves that can be used for speech rehabilitation sometimes. I'll show you X-ray with a coin foreign body and you identify the site of the foreign body. Is it esophagus or larynx? These are the two images. Both are AP view from the front X-ray. In the first, you can see the whole circle of the coin. In the second image, you can see the side rim of this coin. If you can see the whole circle of the coin, then this is esophagus. But in the AP view, if you can see the rim of the coin, the side, then it is either larynx or trachea. Both are correct. Okay. So this will complete throat also. We have done ear, we have done throat, and then we go to our last point, nose and sinuses. Now in the nose and the sinuses, look at the first image. It's showing you the septum. In the second image, you can see the lateral wall of the nose. Septum is more important, the image point of view. In the nasal septum, there are three things that you should be able to identify if they give you the image. You should be able to identify this septal cartilage. This is a bone called vomer bone, if you can read that name. And this bone is the ethmoidal bone. Full name is perpendicular plate of ethmoidal bone, vomer bone, and this is the cartilage, septal cartilage as it is called. Right. Now these are the arteries of the septum. These three arteries, that is sphenoplatean artery, greater platean artery, and superior labial artery, they carry the blood from external carotid artery. And both the ethmoidal artery, that is anti-ethmoidal and post-ethmoidal, they carry the blood from internal carotid artery. So there are 5 arteries, 3 from external carotid, 2 from internal carotid, and the first name, that is sphenoplatean artery, is the most important artery of the septum and the nose. Second point, out of these 5 arteries, the first 4, not this last one, they come together and join with each other to form a plexus called Kisselbeck's plexus. And this area having Kisselbeck's plexus is called Little's area, which is formed by 4 arteries out of 5. And this is important because it's the most common site of epistaxis, which most of us know. We know all these things, right? So epistaxis becomes a very, very important topic. If I ask you, so let's discuss epistaxis. If I ask you which is the most common site of epistaxis, Little's area or Kisselbeck's plexus. If I ask you which is the most common source of bleeding, which is the most common artery of epistaxis, sphenoplatean artery is the artery of epistaxis. What is the cause of epistaxis? Now, most common cause, there are 2 causes. Nose picking is the number 1 cause, and idiopathic is the number 2 cause. Again, the list is very long, but you have to remember these 2 very important causes, nose picking, which is trauma, and idiopathic. What is the treatment? The first thing that we do is nose pinching. Don't confuse, nose picking is the treatment, nose pinching is the cause, nose pinching is the treatment. If this fails, then we do cautery. If this fails, we do nasal packing. If this fails, we do ligation. Okay, this is the sequence that we follow for stopping the bleeding in epistaxis. Now there are 2 very important, 3 questions actually. Number 1, for septal cautery in epistaxis, sometimes we use a chemical called silver nitrate. And this is MCQ. Which is the most commonly used chemical for septal cautery? Silver nitrate. Very, very important. Then second point, if you do ligation of the artery, the most common artery that we ligate is the sphenoplatean artery, SP stands for. And the last artery, when everything else fails, is the anti-ethmoidal artery. That is the last artery that we ligate for bleeding. Okay, so these are the points about epistaxis that you have to know. Now, rhinosinusitis are so many types: allergic, vasomotor, infective can be viral, fungal, and bacterial, and irritative can be many types. Out of so many types of rhinosinusitis, you have to know only two: fungal and the last one, atrophic rhinitis. But before I discuss these two very important type of rhinosinusitis, I want to tell you one thing about vasomotor. In vasomotor rhinitis, sometimes we have to do what is called Vedian neurectomy. It's a surgery of the Vedian nerve. We cut the Vedian nerve and the surgery is called Vedian neurectomy. And they ask you this question that Vedian neurectomy may be required for which of the following diseases? Vasomotor rhinitis. Remember this. And now we come to the two very, very important: atrophic rhinitis. In atrophic rhinitis, there are 5, maybe 6 questions. It is also called Oziana. This is the other name. And out of many causes, most common cause is decreased estrogen. The level of the estrogen reduces and that causes atrophic rhinitis, most common cause. What are the features? What happens to the patient? What are the findings? There is roomy cavity. That means the space in the nose becomes more. There is crust formation. There is foul smell. Plus anosmia. Loss of sense of smell. Now, although there is more space in the nose, roomy cavity, yet because the crust occupies the space in the nose, so nasal block is most common cause. And although there is a foul smell, because the patient has anosmia, the patient is not aware of the smell. And this combination is called merciful anosmia. Both merciful anosmia is a very, very important question. They ask you, merciful anosmia is a feature of which disease? Merciful anosmia is a feature of atrophic rhinitis. Now, obviously, treatment, there are two things they ask you. There is a solution called alkaline nasal solution. And with this solution, we clean the nose in this patient. And cleaning of the nose is called douche. So this whole process is called alkaline nasal douche. Douche is a Russian word which means shower. So we give shower to the nose. But that's not important. What they ask you is the 3 content of this solution. They're all sodium salts. Sodium, sodium, sodium. And how you remember? BBC. The first B stands for bicarbonate. The second B remains biborate. And C stands for chloride. Another very important MCQ. What are the 3 salts of alkaline nasal solution? Sodium bicarbonate, sodium biborate, sodium chloride. I'm writing here, any surgery we can do. I'll give you the name of one very popular surgery called Young's operation. Young's operation might be required in this particular patient. Okay, so 5 points. The name Oziana. Cause, most common cause is decreased estrogen. Features, roomy cavity, dry cavity, crusting and all that. Merciful anosmia is a very, very important feature. The content of alkaline nasal solution for douching, and name of the surgery, Young's operation. So this is one atrophic rhinitis which is important. The other one is fungal. Now fungal rhinosinusitis you see here, there are 4 types. Aspergillosis, fulminant fungal sinusitis, mucormycosis, which is called rhinocerebral mucormycosis, and allergic fungal sinusitis. Now, which fungus causes which fungal sinusitis? Aspergillosis is the most common fungal rhinosinusitis. caused by Aspergillus fumigatus. That's the only thing. They ask you which is the most common fungus, Aspergillus fumigatus. Which is the most common type of fungal sinusitis, Aspergillosis. That's all. Fulminant fungal sinusitis is also caused by Aspergillus fumigatus, but mucormycosis is caused by a rhizopus. Now these two fungal sinusitis, that is mucormycosis and fulminant fungal sinusitis, both are seen in diabetics or patients who have received steroid. What is common in a patient who is diabetic or a patient who receives steroid? Diabetes and steroid both will decrease the immunity of the patient. So these are both immunocompromised person. Okay. And it's a highly invasive fungal disease, both of them. And in both, you have to do gadolinium MRI as the investigation of choice. And in both, the treatment of choice is liposomal amphotericin B plus surgery. Surgery is called face surgery. So these two diseases, almost except the name of the fungus, everything else is very similar. Mucormycosis spreads to the nose, to the orbit and the brain. That's why it's also called rhino-orbitocerebral mucormycosis, because it spreads from the orbit to the brain, to the from the nose to the orbit to the brain. And when it goes to this area, it causes necrosis, which is black in color, and that's why it is called black fungus. Mucormycosis is called black fungus because it causes necrosis, and necrosed tissue becomes to look black. But the treatment remains the same, which is liposomal amphotericin B plus face surgery. And the last fungal disease is allergic fungal sinusitis. You don't have to know the name of the fungus, but there are three main features of this fungus. There is nasal, this is type 1 Ig mediated hypersensitivity, which is type 1 hypersensitivity reaction, which is true for every allergy. Any allergy is type 1 or Ig mediated. There are nasal polyps. There is polyp in the nose. There is a very important thing about this polyp. This polyp in the nose has calcium deposit in it. So nasal polyp with calcium is the main thing, and that's why when you do a CT scan, you can see polyp and calcium, two different densities. That's why the CT scan is called double density. So these are the three things. Remember, allergic fungal sinusitis is caused by allergy, so it's allergic type 1 hypersensitivity. Nasal polyp with calcium deposits are seen, and this finding on CT scan is described as double density scan. So this is the fungal sinusitis you have to know. Now look at this two images. The first one is a CT scan of the sinuses, and this is the polyp. Now look at this polyp. This whole thing is polyp, and inside this different density white thing are the calcium, and this is your typically double density scan. So the moment you see this CT scan, double density scan, straight away you know the diagnosis. This is allergic fungal sinusitis, and this is the black fungus, mucormycosis, due to rhino-orbitocerebral mucormycosis. This is how the black fungus will look like, right? Now we may have to do X-ray for sinusitis. If I ask you, this is a Waters view, this is Pierre's view. Now both are done like this. The first image is showing how the Waters view and Pieris view are done. It's occipito mental view. These are both occipito mental view. From the occipit to the mentum, can you see the first image? What is the difference? This is closed mouth, see mouth is closed, and this is open mouth. This is the difference between Pieris view and Waters view. In Pieris view, open mouth, in Waters view, closed mouth. And this image is a Cardwell's view, which is done for frontal sinus. And this is the most popular X-ray view about the sinuses that they ask you in the exam. Frontal sinus, what X-ray view is done? Cardwell's view, the last view. So if you can identify these three X-rays, that is Waters view, Pieris view and Cardwell's view, that's all. Don't try to memorize any other X-ray views. It's a pure waste of time. Don't waste your time. Your time is very, very valuable. Okay. Then we talk about DNS, deviated nasal septum. So DNS means deviated nasal septum. Most common complaint is nasal block. Excuse me. Now the question they ask you very commonly, if there is a nasal blockage due to DNS, which side nose will block, the same side or the opposite side? What do you think? What do you say? Nasal block will happen mainly on same side of DNS. Obviously, the side which has DNS, the space will reduce and there is all obstruction, but sometimes on opposite side also. Sometimes on opposite side. And now comes a very, very important MCQ. Why should DNS cause obstruction on the opposite side? Everybody knows this answer. This is due to compensatory hypertrophy of inferior turbinate. Due to compensatory hypertrophy of the inferior turbinate. So this is one very important complaint, nasal block. The second important complaint is nasal obstruction, headache. The headache of DNS has a name. What is the headache of DNS called? It's called anterior ethmoidal syndrome. Remember this. The headache of DNS is called anterior ethmoidal syndrome. And what is the treatment of choice? Septoplasty. Or you can do submucosal resection. Submucosal resection is called SMR in short. So there are two different options, surgical option you have. You can do septoplasty, you can do SMR. Now in these two surgeries, the most important thing you have to know is the name of the surgery, incision. In septoplasty, the incision that we use is called Freer's incision. Anybody who knows the incision of SMR, submucosal resection, what is the incision called? It's called Killian's incision. So Freer's incision versus Killian's incision, that's all you have to know in DNS. Okay. So in nose, they are very simple, small topics, very 4 points only, like this one, DNS, like polyps, nasal polyp also. Now what are the properties of nasal polyp? Nasal polyp have poor blood supply and poor nerve supply. Now because the blood supply is poor, nasal polyps are pale in color. They do not bleed. Obviously, if they have two blood supply is poor, they cannot bleed easily. And because of the nerve supply is poor, they are painless. But all this is not important. The most important thing in nasal polyp that they ask you in the exam are the three syndromes that are given below. These are the three syndromes where polyp can be seen, and this is the only thing they ask you. They'll ask you any of the three syndromes, and all the three syndromes have three features. They ask you these features like Sempter's triad can have asthma, polyp, and aspirin sensitivity. Carter-Guinness syndrome and Young syndrome, these two syndromes have two things common. They have both have polyps, they both have bronchiectasis also. The difference in Carter-Guinness syndrome, along with bronchiectasis, polyp, there is situs inversus, which causes dextrocardia. Whereas in Young syndrome, along with polyp and bronchiectasis, the third is not the same. The third is azoospermia that can lead to infertility, right? And then you may know the difference between maxillary polyp versus ethmoidal polyp. Maxillary polyp is mainly seen in children and is due to infection. Ethmoidal polyp is mainly seen in adult and it is due to allergy. Maxillary polyp is called antroconal polyp. This is the other name for maxillary polyp, antroconal polyp. And ethmoidal polyp is called bunch of grapes. They are described as bunch of grapes. Treatment. In maxillary polyp, antibiotics, AMB stands for antibiotic plus face surgery. Ethmoidal polyp, steroid plus face surgery. For any polyp in the nose, face will be done. Here also, both these polyps, face will be required. So mainly remember these three syndromes that are given in the choices. Then we have some granulomatous disease of the nose like rhinophyma. The only important thing in rhinophyma is the image. It's also called potato nose. Last year there was an image based question. They gave an image which is shown in the diagram, in the image shown here in the slide, and they asked the diagnosis rhinophyma, straightway also potato nose, but this is due to hypertrophy of sebaceous gland. Don't try to read anything else. Don't waste your time in this particular. It's very simple disease, but the image is very, very important. Okay. Then rhinoscleroma is an infective disease caused by Klebsiella rhinoscleromatis. Is the name of the pathogen. Klebsiella is a bacterial disease. And it has one more name, like the previous one is called potato nose. This is called woody nose. This is called woody nose. Potato nose versus woody nose. But all this is not important. The most important thing in this particular disease, rhinoscleroma, there are two questions. Either they ask you the histopathology finding, or they ask you in the treatment, they ask you the drug of choice. These are the two most popular questions from rhinoscleroma. So what is the histopathology finding? There are two types of cells. One is called Muculi cell plus Russell body. So if you have a combination of these two histopathological findings, that is Muculi cell and Russell body, these two findings is taken as diagnostic of rhinoscleroma. And the second is drug of choice is streptomycin. If streptomycin is not given in the choices, you can use for rifampicin, can also be used, but plus we do cautery excision also. So these are the two things that we have to do, streptomycin or rifampicin plus cautery excision. And histopathology finding, very, very important MCQ, this one. And there's one more disease in this category, which is rhinosporidiosis. This is also infective disease caused by Rhinosporidium sebarii, which is an aquatic protozoa. So it's a protozoa that grows in water, so aquatic protozoa. But all this is less important. How does it present and the drug of choice? Presentation and drug of choice. These are the two important MCQs from this particular disease. It's called strawberry polyp. Because deep red color growth in the nose. Look at the image which is shown. The growth in the nose is deep red in color like a strawberry, and that's called strawberry polyp. And drug of choice is dapsone. Dapsone, which is given for leprosy, but we also do cautery excision here also. But drug of choice is an MCQ, which is dapsone. Streptomycin in the previous one, dapsone here. But this will complete all the inflammatory diseases of the nose and the sinuses. Infection-related disease, rhinosinusitis, and all this is done. So we have done most of the important diseases of the nose and the sinuses, but we have two more topics to go. Fractures. Now, septum fracture can be of two types. One is called severalate fracture. One is called Jar-Javi fracture. What is the difference between these two fractures? If the fracture is vertical, the fracture line is vertical in the septum, is called severalate, and if the fracture line goes horizontal, that is called Jar-Javi fracture. That's the only difference, and you have to know this. And in all nasal fractures are closed reduction. You understand the meaning of closed reduction? We don't open the nose, we don't give an incision, we just pull and push and align the bones. Then they ask you, what are leaf-foot fractures? Any idea? Leaf-foot fractures are fractures of maxilla. They have types, but all those are less important, so I'm not going to go in that territory. Then fracture of cribriform plate leads to CSF rhinorrhea. The most common cause of CSF rhinorrhea, CSF through the nose, is the fracture of the cribriform plate. So these are the few important fractures out of many that you must know in the nose and the sinuses. But this gives me opportunity to talk about CSF rhinorrhea. You know the most common cause. Fracture of the cribriform plate is the most common cause. Now there are three signs in CSF rhinorrhea you have to know. One is called halo sign. The other name is target sign. Second point you have to know about CSF rhinorrhea, that the glucose content in CSF rhinorrhea has to be more than 30 gram for diagnosis, and presence of beta 2 transferrin is the most specific indicator of CSF rhinorrhea. Now this is MCQ. What is the most specific indicator of CSF rhinorrhea? Is presence of beta 2 transferrin. Very important. Investigation of choice, high resonance CT scan, and treatment, conservative management. It heals and stops on its own, so we don't do anything, conservative management. Okay, so these are the few points about CSF rhinorrhea, 4-5 points, simple. Remember this beta 2 transferrin is the most specific indicator, is a very important MCQ. But this will complete all the important points about the fractures of the facial bone that you have to know, bones on this area. And there are two important tumors you have to know about. One is inverted papilloma. And what do you have to know about inverted papilloma? 3 points only. Number one, it has another name. They ask you this very popular MCQ. What is the other name for inverted papilloma? It's called Ringer's tumor. Very important. Now, out of so many tumors possible in the nose and the sinuses, this is the most popular tumor from the exam point of view. You know why? Because a benign tumor of the nose with malignant potential. That means it has a potential to become malignant in future, and that's why we are so careful about this tumor. You can see the images, you can see the image of a swelling coming out of the nose, red swelling, very smooth swelling. You can see a CT scan with a growth in the nose. You can see an MRI. Now look at that, if you can read that line at the lower end of this image, the MRI finding is described as cerebriform pattern with gyrations. If you can read this cerebriform pattern and gyrations, that means brain-like finding. When you take an MRI of this tumor and MRI of the brain, the shape of the MRI finding looks very similar. The pattern is same as the brain with gyrations. So that is described as cerebriform pattern with gyrations. But treatment is an MCQ. It's excision with a wide margin. We take a margin of 1 to 2 centimeter around the tumor. This is the treatment. The same treatment is also called medial maxillectomy. Same thing, excision with a wide margin, medial maxillectomy, pretty much the same thing. So 3 points: the name inverted papilloma Ringer's tumor has a malignant potential, excision with a wide margin, and maybe cerebriform pattern MRI finding may be important. Now look at this tumor. Esthesioneuroblastoma is a tumor of olfactory epithelium. A tumor of olfactory epithelium is called esthesioneuroblastoma. Olfactory epithelium is the roof of the nose. It's a malignant tumor. So look at the scan which is shown. Look at this CT scan. The second image is a CT scan. This one versus this one. See, in this particular tumor, the tumor is only inside the nasal cavity. It is not breaking into the brain like this. Because it's a benign tumor, it does not infiltrate to the bone. So that's a diagnostic of benign tumor. Versus this tumor, where the tumor has gone into the brain, you can see from the nose, proves it's a malignant tumor. And that's why surgery plus radiotherapy is to be given here. But there are other sinonasal carcinomas which are more common than this particular carcinoma. This is a carcinoma. And because the carcinoma occurs in the nose, maybe sinusosis is called sinonasal carcinoma. The other sinonasal carcinomas I'll talk about. Most common site of sinonasal carcinoma is maxilla, and it is squamous cell carcinoma in the maxilla. Second most common site of carcinoma is the ethmoids. About ethmoid carcinoma, you have to know two things. A, it's an adenocarcinoma. And B, it is seen in woodworkers. And this is a very important MCQ. They ask you in woodworkers which of the following carcinoma is common. Either the choice given is adenocarcinoma or ethmoidal carcinoma. Both are same thing actually. And look at the image. Can you see that yellow line? This is the maxilla of the patient. This line that you see on this image is called the on-grains line. See, if you draw this line, on-grains line, it is crossing the maxilla diagonally. And this on-grains line divides the maxilla into two parts. The part of the maxilla above the line is called suprastructure of the maxilla. Suprastructure. And the part of the maxilla below the line is called the infrastructure of the maxilla. So you can say that on-grains line divide the maxilla into suprastructure and infrastructure. And suprastructure carcinoma has poor prognosis, whereas infrastructure carcinoma has good prognosis. So in a way, if I ask you what is the use of on-grains line, you can see on-grain line helps us know the prognosis of maxillary carcinoma, right? So that's the function of on-grain line. And treatment for all sinonasal carcinoma is surgery followed by radiotherapy is the treatment for all sinonasal carcinoma. So these are very few tumors of the nose and the sinuses. That is, Ringer's tumor is very important. Esthesioneuroblastoma, only that image CT scan which is going in the brain is important. And in sinonasal carcinoma, 2 or 3 points that I have written here, on-grain line, ethmoidal carcinoma is adenocarcinoma seen in woodworkers. These are the important points. So see, in less than 2.5 hours, we have completed ear, nose and throat. So I really hope I've completed ENT, the one-shot revision in less than 2.5 hours. I hope this was very useful. In the last moment before the exam, just watch this 2.5 hours video. It will take care of all the important points of nose and sinuses that you have to know. So I really hope that this session will be useful for you. I thank you for attending this session. Share with your friends, ask them to watch this video. I thank you and I wish you all the best for your exam. May you God take care of you. You've come out with flying colors so that we can meet next year to revise for PG entrance exam, because your ultimate goal is to crack a PG exam, take a PG seat and become a MD, MS doctor. So that should be your target next year, and that can only happen if you complete or clear this particular exam this time around. So good night, take good care of yourselves. Ciao.